Okay, you guys, today I'll give you a little lecture on the thorax, which we'll be doing in lab over the next 2 days. And what I want you to be able to do is to describe the confines and contents of the thoracic cavity, so what makes up its borders and what is inside it. Describe the anatomical structures of the lungs and heart, and describe the parietal and visceral sacs. So the thoracic wall itself consists of the bones that make up the thoracic cage, which is basically your rib cage, your sternum, 12 pairs of ribs and their costal cartilage, 12 thoracic vertebrae and their intervertebral discs, the muscles, fascia, subcutaneous tissue, and skin between the neck and the abdomen. Okay, so because the mammary glands of the breast lie within the subcutaneous tissue of the thoracic wall, the breasts are often considered part of the thoracic wall. But we're not going to be dealing with them a whole lot, so don't need to worry about it too much. Okay, so let's talk about the ribs a bit because they're a big part of the thoracic cavity. They're curved, flat bones, which are very lightweight, but also highly resilient. So they're very light and thin, but they're quite tough. The main purpose of the thoracic cage is pretty much to protect the structures that are inside, right? And it's also they also play a very large role in respiration and breathing because it is a pressure sort of gradient thing, and it also serves to provide attachment for muscles of the upper extremity. So your whole thoracic cage, not the ribs itself, that's their purpose. Okay, so there are 3 types of ribs. There are true ribs, which are ribs 1 through 7, and they are called true because they attach directly to the sternum through their own costal cartilage, and I'll show you a picture of what that looks like. Then there are false ribs, which are 8, 9, and 10. Their cartilages connect to the cartilage of the rib above, and then through that cartilage of the rib above to the sternum. So no direct connection to the sternum. And then 11 and 12 are floating ribs. They don't actually attach to the sternum at all. They're open in the front. Okay, so here you go. Here are your true ribs, right? And you can see they all have a direct cartilage into the sternum, right? And 6 does too, 7 does too. But now look at 8. 8's cartilage connects into the cartilage of 7 and through that into the sternum. Same for 9 and 10. Right, so they connect into the cartilage of the one above, so those are considered false ribs. They're not false ribs, they're ribs themselves, but it's the way they attach that makes them be called false ribs. And then 11 and 12, you see 11 right here and 12, they don't actually attach to the sternum at all, or to the cartilage of the rib above, so they're floating, and those are palpating and become very obvious when you feel them in lab. Okay, 3 through 9 now are considered typical ribs, and they have certain features that are in common. They have a head, which is a wedge shape with 2 facets for articulation with the numerically corresponding thoracic vertebrae, and then also for the vertebrae above it. So it has an inferior facet to articulate with the corresponding thoracic vertebrae, and then it has a superior facet to articulate with the vertebrae above it. They have a neck, which connects the head to the body. Really, that's one of those things on the bone that's just a part of the rib. There's no clear separation of it. It has a tubercle, which is found at the junction of the neck and the body, and this tubercle has an articular facet for articulation with the transverse process of the numerically corresponding vertebrae. So this is an articulation with the transverse process, right? These are the ones that come out the side of the thoracic vertebrae. And then, of course, there's the body or the shaft, thin, flat, and curved. This is where it's most prominent. It's called the costal angle. And on the inferior surface is a groove called the costal groove, which is the intercostal nerve. Travels through that intercostal groove. Again, we may get to see one on the backside when we open up the rib cage and take it off. You may get to see this costal groove, but it's not palpable, and not always that easy to see. Okay, so here you go. Here's your head. Right, here's your superior articulating facet and your inferior articulating facet for articulating with the thoracic vertebrae. And then you have the neck, which is really just a space. And here's your tubercle. This is for, this articulates with the transverse process of the vertebrae. And this joint is something that you can work on. You can mobilize this joint a bit. We'll learn that later. Okay, here's your angle and your costal groove. See, it's literally this little tiny groove on the inferior surface. Okay, your first rib is considered atypical. We call it an atypical rib. It has different functions, does different things. It's broad and short and mostly sharply curved, so it has a much greater curvature here, much sharper curve than your rest of your vertebrae. It only has a single facet on its head for articulation with T1 only. Right? So only one facet, not an inferior and superior. It also has a tubercle called the scalene tubercle. They're not specifically naming the scalene tubercle per se, but obviously it's where one of the scalenes would attach, and it would be the anterior scalene that would attach there. Okay, here, this would be the tubercle here. And then it has grooves to the subclavian vein and artery, which would be right here. Again, these are literally just grooves, not really something you can palpate. You may see them on the cadavers, but not likely. Okay, 2 is also considered atypical. It's closer to the typical ribs than 1, but still has some differences. Its body is thinner, it's less curved, and substantially longer than rib 1, and its head does have 2 facets. But its main atypical feature is a rough area on its upper surface called the tuberosity for serratus anterior, which is an origination site for the serratus anterior. Okay, so you should know by now that serratus anterior does have an attachment to ribs, right? So this second rib actually has a specific sort of, I don't know, sort of a raised area on the rib for the attachment of serratus anterior. So that's the main thing that makes it atypical. So in some texts you're going to see it still labeled as atypical because this is not that substantial to make it different from the other ribs. Okay, ribs 10 through 12 have only one facet on their heads and only articulate with the numerically corresponding vertebrae and not the one above. Okay, so ribs 11 and 12 are short and have no neck or tubercle. Right, here is 11 and 12. 11 is quite a bit longer than 12, so remember that when you go to palpate, because 11 is going to be much farther anterior than 12 is. All ribs have a head, only 1 through 10 have a tubercle. Okay, the costal cartilage is, it tends to prolong the ribs anteriorly and contributes to the elasticity of the thoracic wall. So because the cartilage does have some pliability to it, that is where your rib cage opens up to allow for expansion for breathing. The costal cartilage increases in length through the first 7 vertebrae and then gradually begins to decrease in length as you move down. So the first 7 attach directly to the sternum, right? The first 7 costal cartilage attach directly to the sternum. 8, 9, and 10 articulate with the costal cartilage just superior to them. And 11 and 12 don't actually attach, but they do have a little cap of cartilage on their end, just so make a nice smooth surface. The intercostal spaces, these are the spaces between the ribs and their costal cartilage from one another. They're named according to the rib above, so the 4th intercostal space is between ribs 4 and 5. There are a total of 11 intercostal spaces. The space below 12 does not lay between 2 ribs, so there it's actually considered subcostal. Sub is below, so it's below the rib. The intercostal spaces contain the intercostal muscles and 2 sets of intercostal veins, arteries, and nerves. We'll talk a little more about that later. It's widest anteriorly, become wider with inspiration, as well as with trunk extension and contralateral rotation. So, you have to try to picture these intercostal spaces are somewhat fluid in that they will open up and expand, and they can do that because of that costal cartilage. Okay, so here is showing you innermost intercostal muscles. We'll talk more about these. There are a lot of them. The transverse thoraces muscles, right? And let's see. Here are your. You can see the yellow, blue, and red lines in between here. These are your intercostal vein, arteries, and nerves. Okay, and in between are the intercostal muscles. So all of these are intercostal spaces. Okay? There's a lot on this. You don't need to know all of these structures right now. Okay, we talked a little bit already about thoracic vertebrae and that they have bodies for tubular arteries and 7 processes. We also talked that they have bilateral costal facets on their bodies to articulate with the heads of the ribs. Just to review, T1 through 10 have costal facets on their transverse process for articulation with the tubercle of the ribs. Their long, inferiorly slanting spinous process, right? Remember in lab, I showed a lot of you how the cervical spinous process point directly backwards, but the thoracic spinous process really point downward. Okay, so just to review again, we've already done vertebrae, but you can look again. Okay, another piece of the thoracic cage is your sternum, the flat elongated bone that forms in the middle of the anterior wall of the thoracic cage. There are actually three parts to it. It looks like a single silly bone, but there are actually three parts to it: the manubrium, the body, and the xiphoid process. The point where the manubrium joins the body is called the sternal angle, and it's not much of an angle. It looks more like a line, but there is a slight angle there. And there's a dip on the superior surface of the manubrium called the jugular notch. Right? So that is very palpable right in the center of your chest. Here you go. This would be your jugular notch right here. It looks like the ribs are on top, the vertebrae are on top of it, but they're not. They're actually posterior to it. So there is your jugular notch. This is considered your manubrium. This is considered the body of the sternum, and this is your xiphoid process. Okay, so here is your angle. So right, it looks more like a line, right? But if you look from it from the side, there's a slight angle between the manubrium and the body of the sternum. Okay, there are apertures to the thoracic cavity. You have your superior aperture and your inferior aperture, basically holes. Because if you look at this rib cage in and of itself, it's a circle. It's around the circuit, not round, but it's circular, and it has, these are just openings. So there's an opening at the top, and there's an opening at the bottom. Aperture means doorway, kind of. Okay, so superior aperture is between the thoracic cavity and the neck and the upper limb, and the inferior is between the inferior, sort of where your diaphragm sits, is the biggest thing you need to know, and your abdominal viscera is there as well. So in the superior thoracic aperture is also sometimes called the thoracic inlet. Its boundaries are the T1 vertebrae, the first pair of ribs and costal cartilages, the superior border of the manubrium. Structures that pass through your superior thoracic aperture are your trachea, your esophagus, and nerves and vessels that drain the head, neck, and upper limbs. So a lot of important structures passing through that area. The inferior thoracic aperture is also called a thoracic outlet. Right? Makes sense. Inlet at the top, outlet at the bottom. It outlines the attachment site for the diaphragm. Its boundaries are T12 vertebrae, posterior laterally the 11th and 12th pairs of ribs, anterior lateral is called the costal cartilage of ribs 7 through 10, and anterior the xiphosternal joint. Structures that pass through this are your inferior vena cava, your near esophagus, pass through to the diaphragm, and the aorta passes posterior to the diaphragm. Okay, so we have several joints here, and we're going to talk about them just briefly, and then a lot more. We'll cover the joints in kinese. So the joints that you have are your vertebrae. You have your intervertebral joints, right? We talked about those facet joints. There's also a joint between the bodies of the vertebrae. You have the joints between your ribs and your vertebrae. We said the heads of the ribs articulate with the transverse processes. The ribs and the costal cartilage are also considered a joint, and they're called a costochondral joint. And then the costal cartilages are the intercostal joints. You have articulation between your sternum and the costal cartilage, called the sternocostal joint. Your sternum and the clavicle, the sternoclavicular joint. And then the parts of the sternum, the manubrial sternal and the xiphosternal joints. Not really, I have to say these last two are really not considered joints per se, because there's very little movement that occurs there, but for being technically correct, we'll say they're joints. Okay, sternoclavicular joint, right? Articulation between the clavicle and the sternum. So this is your manubrial sternal joint, not a lot, and your xiphosternal, again, not a lot. Intercostal joint, right, between the cartilage of the rib above and below, and then the costal chondral is between the bony part of the rib, and as it transitions into its costal cartilage. Okay, movements of your thoracic wall, and we'll again do this in kinese, but during inspiration, the dome-shaped diaphragm contracts, which causes it to move inferiorly and sort of flatten out. So the inferior superior dimension of the thoracic cavity sort of increases, right? And then in anterior posterior dimensions are increased by elevation of the superior ribs and the costovertebral joints. Right, so when the ribs elevate, it causes the sternum to be pushed forward or anteriorly, right, away from you. And that increases the distance between the sternum and the vertebral column. So if you think of your sternum anteriorly, and your vertebrae posteriorly, when you inhale, your sternum moves farther away from your vertebrae. And transverse-wise, the dimensions increase by elevation of the lower ribs of the costovertebral joints. Okay, so basically what you see is that your whole rib cage expands, right, in all three directions, anteriorly, laterally, and transverse-wise, right? It just opens up in all three planes. We call it a bucket handle sort of thing. So if you think of a pump handle, right, there's a pump and a bucket handle. And again, you don't have to worry too much about this because we are going to do this again in kinese. But the way your ribs move up when you're inspired, your lower and upper ribs move differently. Your lower ribs look more like this pump handle, and your upper ribs move in a fashion sort of like a bucket handle, like when the bucket handle moves from down against the bucket to up and away. Okay, so, but basically what I want you to understand there is that there is movement of the thorax. It's greater inferiorly than it is superiorly, and the way that it happens is different anteriorly to inferior. Superior to inferior. Okay, back to what we are focusing on in anatomy, the muscles of the thoracic wall. Serratus posterior superior and the serratus posterior inferior, right? We already saw those little tiny muscles, practically do-nothing muscles. The levator costarum, if you think about that, levator costarum, levator elevates, right? Costarum, ribs, so it elevates the ribs. Your internal and external intercostals, your innermost intercostals, and your transverse thoracic muscle. Okay, so this is going back, it's a little out of place here, but you're back in the intercondral spaces, and it's showing your vein, artery, and nerve, how they run through the intercostal spaces. Okay, your typical intercostal nerve, it comes off your intervertebral foramen, impacts in the sympathetic chain to the posterior dorsal ramus, to the main nerve, sends off a lateral cutaneous branch and an anterior cutaneous branch. Okay, so the lateral cutaneous is going lateral trunk, anterior is going to anterior trunk. Intercostal arteries and veins. There's one posterior intercostal artery in each intercostal space. They arise directly off the thoracic part of descending aorta, and they supply the posterior part of the thorax. There are two anterior intercostal arteries in each intercostal space, and these arise off the internal thoracic artery, which is a branch of the subclavian, and supplies blood to the anterior and lateral aspects of the thorax. The two anterior and one posterior intercostal arteries join together laterally in the intercostal spaces. Okay, let's talk a little bit about the viscera that is in the thoracic cavity. You have right and left pulmonary cavities, which house the lungs and the pleura, which are lining membranes, and you have your mediastinum, which is between the two pulmonary cavities, and that's where all your major, the rest of the major structures are found. Your heart, thoracic part of the aorta, and other great vessels, the thoracic part of the trachea, esophagus, thymus, and lymph nodes. Okay, so here are your pleural cavities, right, one on each side, and everything in here is considered mediastinum. So a little bit about the lungs first. Each lung is invested and enclosed in a pleural sac that consists of two continuous membranes. Right, the visceral pleura, which invests all surfaces of the lungs, forming their shiny outer surface. Right, we've seen that shiny outer surface in some of the muscles as well. And then the parietal pleura, which lines the pulmonary cavities. So you have to sort of think of it as two envelopes, really, is what they are. One that lines the whole pleural cavity, and one that is actually going around each of the lungs itself. Okay, so you have this would be the visceral going around the lung itself, and then this doesn't show it very well, but there is one that is encompassing the whole thing, which would be the parietal pleura. You can see it here a bit underneath here. Right, so they name this parietal pleura by where it is. We'll talk a little bit more about it. So since there's parietal and visceral pleura, right, and they're separate structures, but they are continuous at a certain point, the space between those two pleura is called the pleural cavity. So this is a potential space that is normally filled with pleural fluid, which serves to lubricate the pleural surfaces and allows the layers of the pleura to slide smoothly over one another during respiration, right? So if your rib cage is expanding during respiration, so do your lungs, right? So your lungs expand. So this fluid in the pleural cavity acts sort of like we talked about bursts around the muscles and bones. They're cushioning. It's a viscous fluid for it to float in. So the parietal pleura lines the pulmonary cavity and adheres to the thoracic wall, the mediastinum, and the diaphragm. So this is the big outer envelope. There are 4 parts of it, and again, they're named by where they are. So the costal part covers the internal surface of the thoracic wall. The mediastinal part covers the lateral aspects of the mediastinum. The diaphragmatic part covers the superior surface of the diaphragm. And the cervical part extends through the superior thoracic aperture into the root of the neck, forming a cup-shaped pleural dome over the apex of the lung. Okay, so here you go. Here's your cervical part, right? Superior cervical. You've got your mediastinal parts because your heart is right here, so obviously they're near your heart. Your diaphragmatic, because your diaphragm is going to be sitting down here on each side. And then you have your cervical pleura again up here. And your costal part. Right? Your costal is this blue line here coming along the ribs, obviously. Okay, so the parietal and visceral pleura are actually continuous with each other at certain points. So at the hilum of the lung, which is where all the structures enter and leave the lung, right? And this continuity forms an empty double layer of pleura that hangs down from the hilum when the lung is removed from the body. This is called the pulmonary ligament, which you should be able to see when we dissect. Okay, lungs, obviously organs of respiration. Their main function is to oxygenate the blood. Right? The lungs are separated from each other by the mediastinum and attached to the mediastinum by their roots. The root of the lung is what attaches to the heart and the trachea. And the root of each lung is made up of the bronchus, the pulmonary artery, pulmonary veins, bronchial arteries and veins, pulmonary plexus of nerves, and lymphatic vessels, all bundled together by pleura. There are differences between left and right lungs. The left lung is smaller than the right, has an indentation called the cardiac impression on its medial aspect, and that accommodates the apex of the heart. This indentation creates a thin tongue-like process of the superior lobe referred to as a lingula. Okay, you'll be able to see this indentation for the apex of the heart when we remove the lung. The apex is the blunt superior end of the lung, right, and it actually ascends above the level of the first rib into the root of the neck. Each lung has 3 surfaces, costal, mediastinal, and diaphragmatic, right? Obviously that tells you where they are. And 3 borders, an anterior, an inferior, and a posterior border. Okay, so here are your apex. This is your left lung, right? Notice 2 lobes, superior and inferior, and the right has 3 lobes, a superior, a middle, and an inferior lobe. They have fissures, which are just these lines that separate the lobes. So on the right, you have a horizontal fissure and an oblique, and on the left, you just have the oblique fissure, okay? Here is that cardiac notch for the apex of the heart. Okay, this is considered the root, right? So here are all your structures of the lung. So you're looking, you're looking from medial to lateral. So you're looking from near the heart out laterally. So this is the interior surface of the right lung. Okay, and here you have your right inferior pulmonary vein. This is your right superior pulmonary vein, right intermediate bronchus, and your right pulmonary arteries. And these are the little orange things here are lymph nodes. Okay, so all this is considered the root, and these are the structures that pass through them. And here's your left, just slightly different orientation. Okay, the trachea is located within the superior mediastinum and makes up the trunk of the tracheobronchial tree. Trachea bifurcates or splits at the level of the sternal angle into main bronchi, 1 to each lung. Each main bronchi branches into lobar, secondary bronchi, 2 to the left and 3 to the right, because the right has 3 lobes, left has 2, each supplying a lobe of the lung. So each lobe or bronchus divides then into several segmental bronchi, which supply the bronchopulmonary segments. Okay, so here, this is all your bronchial tree. You have your right main bronchus that comes into the right superior bronchus, and then continues on down into the right lower lobe bronchus. And then you have your bronchi going to the middle lobe as well, right? So you're only going to have two of those on the left one. Bronchopulmonary segments are pyramidal-shaped subdivisions of the lobes. They're separated from adjacent segments by connective tissue. They're supplied independently by a segmental bronchus and a branch of the pulmonary artery and drained by its own branches of the pulmonary veins. Surgically resectable, which means you can take it out. Usually there are 18 to 20 between the two lungs. Okay, the trachea and the bronchi. Between the tertiary bronchi are from 20 to 25 generations of branches that eventually end in terminal branches. And no, you don't need to know 20 to 25 branches. You just need to know that they continue to branch. Each terminal bronchiole gives rise to several respiratory bronchioles. These respiratory bronchioles provides 2 to 11 alveolar ducts, which then give rise to alveolar sacs, and finally to the alveolar, which is where your actual gas exchange takes place. Okay, vasculature of the lung. Each lung has a large pulmonary artery supplying the blood to it, 2 pulmonary veins draining blood from it. Bronchial arteries supply oxygen and nutrient-rich blood to the lungs and the visceral pleura. The bronchial arteries are branches directly off the thoracic part of the descending aorta. The parietal pleura is supplied by the intercostal arteries, since the parietal pleura is adhered to the thoracic wall. Your nerve innervation here, there is a pulmonary plexus of nerves. It's a group of nerves which receive sympathetic contribution from the sympathetic trunks, parasympathetic innervation from the vagus nerve. And no, you don't have to know this plexus. Parietal pleura is innervated by the intercostal nerves and the phrenic nerve. Okay, your mediastinum contains all the thoracic viscera and structures except the lungs. It extends from the superior thoracic aperture, or the thoracic inlet, to the diaphragm inferiorly. 2 sections of it. The superior extends inferiorly from the superior thoracic aperture to a horizontal plane between the sternal angle to the intervertebral disc between T4 and T5 posteriorly. And then inferior extends from that plane to the diaphragm, and then further subdivides into anterior, posterior, middle parts by the pericardium. The middle section of this is where the pericardium actually lies, and anything anterior to it is the anterior mediastinum, and posterior is the posterior. Pericardium itself is a fibrous membrane that covers the heart and beginnings of the great vessels. It's enclosed sac composed of 2 layers, a very tough external layer that we call the fibrous pericardium, and an inner layer called the serous pericardium. The fibrous pericardium protects the heart from overfilling and helps anchor it in place. Right? So anteriorly it attaches to the sternum. It's bound posterior by loose connective tissue to the structures in the posterior mediastinum, and inferiorly with central tendon of the diaphragm at the pericardiophrenac ligament. Okay, so the fibrous pericardium pretty much holds your heart in place. The serous pericardium is deep to the fibrous, has 2 layers, a parietal layer, and again the visceral layer. Sound like the heart? Okay, the pericardial cavity is a potential space between opposing layers of the parietal and visceral layers of the serous pericardium, again just like the lungs. Normally contains a thin film of fluid that enables the heart to move and beat freely in a frictionless environment. Again, same as the lungs. Your main blood supply to the pericardium is through the pericardiophrenic and musculophrenic arteries, which are branches off the internal thoracic arteries. There are also arteries that arise directly off the aorta in the thoracic region called the pericardial arteries, and they supply the pericardium. Coronary arteries are the first branches off the aorta, supply the visceral layer of the serous pericardium only. Venous drainage is through the azygos vein system, and nerve supply comes from the vagus nerve, right? Cranial nerve, we already learned that, and the phrenic nerves, and from the sympathetic trunks. Okay, hopefully you know all this, so I'm going to go through this quickly. This should be reviewed for most of you. 4 chambers, right and left atria, right and left ventricles. Walls of each chamber consist of 3 layers, the endocardium, the myocardium, and the epicardium. And there it is. There is your heart, right and left atriums. The heart consists of an apex, a base, and 4 surfaces and 4 borders. Terms are based on the description as the heart is a trapezoid. The apex is formed by the inferior part of the left ventricle, lies posterior to the left 5th intercostal space, about 9 centimeters from the median plane in adults. The base is at the opposite end, posterior side, and extends from the pulmonary trunk inferior to the coronary groove, formed mainly by the left atrium with a lesser contribution from the right atrium. Remember, your heart doesn't sit straight upright, right? It's turned a bit to the side on an oblique angle. Anterior surface is also called the sternocostal surface because that's right where it is. It's mostly the right ventricle. Diaphragmatic surface, obviously inferiorly, formed by both ventricles, more left than right. The right pulmonary surface is formed mainly by the right atrium. The left pulmonary surface is formed mainly by the left ventricle. 2 grooves visible on the outer surface of the heart. The grooves mark the boundaries of the 4 chambers and carry the blood vessels that supply the myocardium. Anterior interventricular groove separates the right and left ventricles. Obviously, it says interventricular. And the posterior does that posteriorly. The atrioventricular groove, also known as the coronary groove, separates the atrium from the ventricles and encircles the junction of the atrium and ventricles like a crown. Okay? Anterior interventricular groove. Your coronary or your atrioventricular groove, your posterior interventricular groove. Okay, so the atria are the receiving chambers for blood returning to the heart from the circulation. Blood enters the right atrium via 3 veins, the superior vena cava, the inferior vena cava, and the coronary sinus. Right, and there they are. And blood enters the left atrium via 4 pulmonary veins, which transport blood from the lungs back to the heart. And there they are. Together, the ventricles make up most of the mass of the heart. They're much larger than the atria. The ventricles are discharging chambers, the actual pumps of the heart. So that when the ventricles contract, blood is propelled out of the heart into circulation. The right ventricle pumps blood to the pulmonary trunk, which routes blood to the lungs for gas exchange. And the left ventricle pumps blood to the aorta, where it is then circulated all over the body. Okay, you all know about the valves. I'm sure they keep blood in check. They allow, make sure there isn't backflow from atria to ventricle. 2 atrioventricular valves, 1 at each atrioventricular junction, prevent backflow of blood into the atria when the ventricles contract. You should know the names. I'm sure we get this in high school, the tricuspid, bicuspid, or mitral valves. Each of the AV valves flaps are tiny white collagen cores called chordae tendineae, or heartstrings, that anchor the cusps up to the papillary muscles which protrude from the ventricular walls. So your little flaps here. See how they attach to the ventricular walls? And here they are again. Right here, attaching to the ventricular walls. As blood fills the atria, the pressure that builds up causes AV valves to open, and that allows blood to flow from the atria to the ventricles. And the AV valve flaps down, hanging down into the ventricles. As the ventricles contract, blood is pushed against the cusp of the AV valves, causing them to close. The aortic and pulmonary semilunar valves prevent backflow of blood from the aorta and pulmonary trunk, in case once they're leaving, it can't come back. Each valve is formed from 3 pocket-like cusps, each shaped roughly like a crescent moon. So when the ventricles contract and the interventricular pressure exceeds the pressure in the aorta, pulmonary trunk, the semilunar valves are forced open and their cusps flatten against the arterial walls as the blood rushes past them. Once they relax and the blood begins to flow backwards through the heart, blood fills the cusps and the valves close again. Okay, and there's your tricuspid, your pulmonary valves. And here is your aortic valve. So there are no valves guarding the entrance of the vena cava and the pulmonary veins in the atria. Small amounts of blood do spurt back into these vessels during atrial contraction, but the blood backflow is largely prevented because the atrial myocardium compresses and collapses these venous entry points as it contracts. So a little bit of leakage. Okay, so review of blood flow. I'm sure you can even find tons of animations online that take you through this. Deoxygenated blood enters the right atria through the superior and inferior vena cava and the coronary sinus. Once the right atria is filled, the tricuspid valve opens and this deoxygenated blood is dumped into the right ventricle. Once the right ventricle fills, the pulmonary semilunar valve is pushed open and blood enters the pulmonary trunk. The right and left pulmonary arteries are formed off the pulmonary trunk and carry deoxygenated blood to the lungs for oxygenation. Once they enter the lungs, the pulmonary arteries branch out in similar fashion to the bronchi and eventually terminate on the alveoli. The structure of the veins that moves from smaller to larger and eventually terminates as pulmonary veins carries freshly oxygenated blood back to the left atrium. Once the left atria fills, the bicuspid or mitral valve opens and the oxygen-rich blood then enters the left ventricle. When the left ventricle is filled, it contracts and blood is pushed into the aorta, where it's circulated all around the body. Okay, and there's just an image of it. And like I said, there are tons of animations of this available online. Okay, your aorta, pretty important stuff, divided into three parts: the ascending, the arch, and the descending. The only branches off the ascending aorta are the coronary arteries, which supply blood to the heart itself. Off the aortic arch is the left common carotid artery and the left subclavian vein and the brachiocephalic trunk. Okay, and there they are. Just your three branches off of the transverse. And then, let's see, nutrient and oxygen-rich blood is supplied to the heart through the right and left coronary arteries, which arise from the ascending aorta. The left coronary artery runs toward the left side of the heart and divides into two main branches, the anterior interventricular artery and the circumflex artery. And there they are. The right coronary artery courses to the right side of the heart, and it divides into two main branches, the marginal artery and the posterior interventricular. Okay, and here's your posterior and your right marginal. After passing through the capillary beds of the myocardium, venous blood is collected by the cardiac veins, whose paths follow roughly those of the coronary arteries. So the cardiac veins then join together to form an enlarged vessel called the coronary sinus, which empties blood into the right atrium. And here is your coronary sinus. Here's your left posterior ventricular vein, left marginal vein, and the great cardiac, all forming this larger sinus. Nerve supply to the myocardium is a cardiac plexus of nerves, a complex group of nerves formed by both sympathetic and parasympathetic and pathetic fibers, right? Makes sense, you need to be able to speed up and slow down your heart. Okay, briefly, the posterior mediastinum. In addition to the trachea and thoracic aorta, other important structures in the posterior mediastinum is the esophagus, thoracic duct and lymphatic trunks, and the azygos system of veins. The esophagus descends into the posterior mediastinum from the superior mediastinum, passes posterior into the right of the aortic arch, and posterior to the pericardium and left atrium, and then deviates to the left side and passes through the esophageal hiatus to the diaphragm. Okay? But a bit on the thorax, and you'll get to see a lot of this. We're going to take both the lungs and the heart out of the cadavers, so that'll be fun to play with. And I will see you tomorrow.